You can, Segin, you can put your hand. That's right. Okay. Switch on your audio as well. Segin, you can put your hand. That's right. Okay. Switch on your audio as well. Segin, you can put your hand. That's right. Okay.
You're echoing, Dr. Bhupsen.
Audio as well.
The beginning, your
Segin,
words are
you can
beginning.
put your hand. That's right. Okay.
You're echoing, Dr. Bhupsen.
Audio as well.
The beginning, your words are beginning.
Put your hand. That's right. Okay.
You're echoing, Dr. Bhupsen.
Audio as well.
The beginning, your words are beginning.
That's right. Okay.
You're echoing, Dr. Bhupsen. The beginning, your words are beginning. You're echoing, Dr. Bhupsen. The beginning, your words are beginning. Good morning, Dr. Bhupsen. I think there is something that is creating echoing in your audio. No, you're muted now. You're muted now. Muted now.
Can you
You're muted now.
mute your Facebook account?
Muted now.
Can you
You're muted now.
mute your Facebook account?
Muted now.
Can you
You're muted now.
mute your Facebook account?
Muted now.
Can you
You're muted now.
mute your Facebook account?
Muted now.
Can you
You're muted now.
mute your Facebook account?
Muted now.
Can you mute your Facebook account?
Yes, sir.
Can you mute your
Better now? Yeah, that's fine. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in same audio pitch. You are muted now, Dr. Bhupsen. Hope we are in What's wrong with the audio? Facebook stop ചെയ്യാൻ പറ്റുമോ? Wait.
Can you hear me now? Can you hear me now? Yeah, I think the echo was coming from the Facebook part. Yeah, I think the echo was coming from the Facebook part. Yeah, I think the echo was coming from the Facebook part. Yeah, I think the echo was coming from the Facebook part.
Still echoing.
Was coming from the Facebook part.
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 Echoing.
Can you speak up, Segin? Let's see if it's yet echoing. Can you speak up, Segin? Let's see if it's yet echoing. Can you speak up, Segin? Let's see if it's yet echoing.
From your side, it was echoing, Dr. Bhupsen.
Let's see if it's yet echoing.
From your side, it was echoing, Dr. Bhupsen.
Let's see if it's yet echoing.
Both sides, it is getting repeated. It was echoing, Dr. Bhupsen. It is getting repeated. It was echoing, Dr. Bhupsen.
Okay, what I'll do is I'll stop the Facebook. Okay, what I'll do is
Facebook live streaming, I believe.
Okay, what I'll do. Hello?
Yeah, it is better now.
Yeah, I think the Facebook Live is causing a problem.
It's okay.
We will not get on to that. I think we already have a few participants who have logged in, and it's time to start. So let's do without the Facebook. We can try it later on how to put it onto the system. Okay, so a very good morning and a good Sunday for all of you to be here this morning. It's really exciting. We have with us today with Dr. Segin Chandran. Welcome to Digital Dental Forum webinar once again. I think you've been on this platform earlier with us also, and it's great to have you back here. Just to introduce Dr. Segin, Dr. Segin has been an eminent oral and maxillofacial surgeon and an implantologist practicing for over 26 years. He is the chief surgeon and director of Kamala Dental Specialty Hospital Center, known for its dental and surgical treatments for teeth as well as face. He's also a senior consultant at to the SP Medifort Hospital, PRS Hospital, and the JJ Hospital, Thiruvananthapuram. His ideas of expertise include trauma care, orthognathic surgeries, and dental implants-based full mouth rehabilitations. Dr. Sejan Chandra was awarded a fellowship and a diplomat certificate in implantology by the ICOI and holds both fellowship and mastership from the Indian Society of Oral Implantologists, that is the ISOI. He is also well known for his digital protocols in surgery, in implantology, and is the key opinion leader for various dental implant manufacturers. He has won the FAMDent Excellent Dentistry Awards for specialist dentist, as well as his practice. Kamala Dental has won the Best Dental Hospital for the year 2022. Received the FAMDent Star Awards in 2025 for achieving and maintaining excellence in dental practice. So he's well acclaimed speaker as well. He's also been bestowed with the Dr. Abdul Kalam Lifetime Achievement National Award in 2019 and contributions to the field of digital dentistry. Surprisingly, he yet pursued his PhD in oral implantology and in the subject of accuracy of digital protocols in immediate placement of implants and extraction sockets in 2024. And of course, he has numerous national and international publications to his credit. So, who better can be introduced as an digital implantologist? Welcome, Dr. Sejan, once again. And we really look forward to your presentation today, which is on digital implant workflows. Today's will be the part one, which will take care of all the surgical aspects. And a few months down the line, we will have the part two, which will take care of all the prosthetic aspects as well. So all you participants, please use the chat on the Zoom option to put in all your questions and queries and post the presentation. We will be doing a question answer session with Dr. Sejan. I now hand over to Dr. Sejan to take care of the presentation. Thank you.
Very warm good morning, and many thanks to Dr. Bosin Khan and team Digital Dental Forum. And it's very gratifying to address my fellow colleagues with the knowledge what I acquired in digital dentistry and implantology for many years. And let me start today's topic on how to digitalize your implant workflow. We all are masters of our subject and we do decent enough dentistry and implantology. Whoever is trained in implants, they'll be confident in doing single, multiple, and even full mouth rehabilitations with implants. And when patients demand, we never hesitate to offer them this kind of services. But when we look back, how good it was through our hands, many times we feel, I could have done it much better. Yes, it's true. Like many times we do very accurate planning, but not that accurate surgery. When we see a very good implant placed in the mouth through our hands, and when the prosthetics is very optimum and the occlusion is maintained and it is giving longevity in long run, we feel so happy. But what about the lost cases through our hands? Why did we lose them? That is what we wanted to just look out. And Now, after many years, after starting my implantology practice, what is happening through my hands? When I evaluate how I do the planning and how I execute, is it very precise? Is it very predictable? Then I have to look back to the days of my analog dentistry and even to the digital side. The analog dentistry was not bad. We were very cautious about where we are drilling to. We are making the regular surgical templates using vacuum formed trays or otherwise removable partial denture sort of things, and drilling into the ideal position that is in exactly in the long axis of the prosthesis, trying to be more prosthetically driven. But when we look at the digital dentistry, it is all there. There is no other option other than just going through the prosthetically guided workflow. And the norms have changed. Now we cannot rely on our RVG or OPG for our implant workflow, and the CBCT and the 3D norms have set in. When we consider the posterior mandible, is it reliable to be on a two-dimensional evaluation? No. Many times you will be surprised to see that our implant, the possibility of giving an implant in the posterior mandible will be very much conceived, like it will be this one shown as a good amount of length and width in the two-dimensional workflow. But it will be very deceiving to see that in the this on CBCT, when you see, the things are entirely different. We have only 7 millimeter, otherwise we will be hitting the lingual cortex, and we cannot go further, and our implant will be stuck half the way. So how to give this precise, very much three-dimensionally oriented, prosthetically driven, accurate dental implant placements, like bullseye shots every time? Can we rely on the digital or otherwise the guided workflow? Is it reliable? Way back in 2019, there was an article where it evaluated all the possible, the accuracy levels of digital guided systems. But now when we are in 2025, the things have changed a lot. The guided, the advantages everyone knows. We can have good parallelism, we can have good primary stability, we can have, above all, we can have zero bone loss in long run. See, these two cases, both are done by me, myself, very long back in an analog way, and giving a platform matching implant and giving a prosthesis. After 7 years of follow-up, you see the implant is still surviving. There is no issues. It is retained in the mouth. It is in function. But see the bone loss around it. But it is a stable remodeling. It is not that it is failing, but it is a stable remodeling. But at the same time, the digitally planned, guided, subcrustally placed, platform shifted implants with a good prosthesis showing zero bone loss even after 5 years. So what we need to prefer is very predictable outcome from our side. And when you wanted to achieve such kind of long-term results with a zero bone loss, we need to have good soft tissues also around it. Nowadays, what I do is I get the implants into the ideal position, then I work on my soft tissues. This zero bone loss concept was evolved by Dr. Thomas. He worked from 2018 to 2019, almost 11 years of his research. He came out with the concept of having minimum 3 millimeters of soft tissue, subcrustally placed implants, giving the temporary prosthesis or the anatomical healing abutments in such a way that we get very predictable soft tissue profile and even good primary stability and zero bone loss, and whatever you wanted to see in posterior or anterior implant placements. With the good trajectories, the implants are placed in the anterior segment, then the aesthetic biologic contour is the outcome. So how we go about with these digital protocols for implantology? It saves a lot of time as it is around the 80% planning and preparation and 20% time taken for the execution. See this, now we are very much matured in digital dentistry protocols that we can even think about one-day implants, that if you're very sure about the soft tissue thickness, and if you're ready with the anatomical temporization, and if you're ready with your temporary crown, properly oriented to the hex position in advance, we can place the temporary crown and we can send the patient today. That means your treatment time from the patient
Sir, your
consult.
voice is low.
Please mute yourself, doctors, all of you. See, from the time we talk to a patient, and when the patient is saying, I'm okay for it, let's go ahead. From that time till the execution, how much time you take. That is starting off your surgery from the time of patient visiting you. Previously, it was many days. Now it is in one day, in few hours. That means our patient conversion to the dental implant procedure has cut short in a time span of half a day, or at least 3 to 4 hours time. Then the productivity is much more, and it takes very less time for the execution because it is guided. Our time taken to orient ourselves to the three-dimensional placement of implant is very, very less. So reduced chairside time, increased productivity, and high returns on your investment. Everyone says digital dentistry is very expensive, very much this on challenging, as it may cost you a lot, and whether we will get the exact returns for this investment. I will say there are always direct and indirect returns for your any investment made in dentistry. Maybe the number of CBCTs you take, the number of scans you take, and divided it by the days, then you may not have the same equation. But the amount of workflow, what you can do in a day or a week or a month, and how much you completed your the committed procedures in a limited span of time, then you will very much understand how profitable and how good it is a return for your investment. So why everyone is not opting for this digital dentistry is, there are few challenges in front of you. One is higher learning curve. You have to dedicate your time. You have to be in this on abreast with the new technologies, new equipments, how it functions, its basic fundamentals in working, and you have to get them to practice. You have to invest and on your time, and then you have to invest on the pricing. Then you have to maintain that. Then once you do it, it is like learning the bicycle ride. It's very this on yeah, when you see from a person who is not riding a bike or a cycle, they will think that okay, it is very dangerous and how they are managing. But the one who started the first lessons, okay, they fall, they get up, and then again and again they try, but end of the day they become the master. And anytime in their lifetime, they will be able to do these procedures without fear. So the same thing applies to even oral implantology. You would have done some trials, but maybe it was not that fruitful. But don't hesitate to go ahead. Now let me tell you my experience with the digital dentistry and how I started the digital protocols in my practice. It was way back, much before I invested on the heavy gadgets into my practice. It was in 2009 that I did my first guided full mouth surgery, that too with Nobel Biocare. I didn't have my CT machine. I took the patient to the CT scan, took the regular CT. It was too much of radiation to the patient, but the patient was okay for it. And she told, you do whatever you want, but I need the best fixed option in my mouth. And I don't hesitate to spend on, but give me the best results possible. I extracted, waited for a few weeks. Then again, I created a temporary denture. Sorry, why it is giving this screen lines? I have no idea. Okay, again from starting from this denture, making the this on radio opaque fiducials with the Gattaperka, then scanning the denture, creating the soft tissue profile, and again the hard tissue, this on CT scan. Both were sent to Sweden, and they did the matching and they did the implant planning for me. Let me tell you, dear friends, I had very less control over the entire happening. And I will say that though it was my first experience, it was very much gratifying. And it gave me a lot of confidence in thinking about the futuristic way of going digital. All 6 plus 6 12 implants, all were successful, all were in place. Though it took around 55 days for that gate to come from Sweden. And when I opened it, with the help of the Nobel Biocare person in my practice, I did the first surgery, and I will tell you, all the implants were integrated well. Though I didn't get the exact placement like I planned, and some of the implants were slightly tilted, and some of them were not gone exactly into the bone. It was 1 or 2 millimeters above. That time, even I was also very novice that I just got all the implants in place. I wanted to fix in my prosthesis, and I did that. Let me tell you, 16 years now, still that lady is with that denture, and she is not ready to change the acrylic part of the denture part of it even now. She says, I don't want to remove it and wait for another 10 days for the workflow to complete. So this gave me a confidence, and I documented this case, and we gave a case report in the this one in our publication in 2009. And later, I got the confidence to make most of the things in house, and we continued with the gates fabricated from the third party options, and did once in a while the gated surgeries. But my gated surgeries became so common and so frequent only after me integrating this digital protocol into my practice, and I started investing, training, and integrating my team into this. And now we are evaluating and upgrading, and this is a never-ending story. At Kamala Dental, now we have, though we started as a very humble, simple practice in 1999 as a solo practice, we were very keen on where we are progressing to. And now, in this 25 years of span, now we have 15 doctors, 9 of them specialists and 6 general dentists, altogether 43 staff. And we all discuss together our cases in our daily meetings, and we try to give our best to our patients. And in that, one more discussion what we have is what is next. From CBCT, then to intraoral scanning, whenever we tried to get the latest and the upgraded version of the digital equipments. And again, we have the latest face scan now. We can now create a virtual patient in our practice by having the bone dimensions and the soft tissue profile intraorally, and even the face profile of a patient. We can create these virtual patients in our system, and we can do smile designing, we can do denture fabrication, we can do implant placements, any kind of dentistry and surgical practice. Me being a maxillofacial surgeon, I am more into orthognathic surgeries and trauma care. And in orthognathic surgeries, we segmentalize this on scans, and we see the different options for setbacks and with the BSSO or left foot, and we do digitalize our maximum procedures now. Now our thought process is what to do more with the digital dentistry. With the 1:1 patient in your hand, you can always create the type of procedures you wanted to do digitally. And it is always better to try the simple procedures first in digital, and then to go step by step in advancing in your career to make your practice and yourself more digitally oriented. We got the best 3D printer possible from Asiga. We had a lot of glitches in getting the 3D printing sorted out in our practice. We started with many other brands, the cheaper and expensive ones, and it was giving some trouble. And then we also had a learning curve, and we decided to go for, though a little expensive, the best one possible, because it gives freedom, and it will print your models and it will print your surgical gates as you need and without any technical errors. And we moved on much more to the milling and the manufacturing of prosthesis our own, that is by CEREC, chairside economic system, where we are milling now all our crowns. Most 99% of our workflow is through CEREC. We usually I am doing more of a short span bridges of short span implant procedures, and very rarely, once I do the full mouth implant procedures only, I have to depend on the lab for the full frameworks. Otherwise, we are very happy to do with the SEREC. And this is my lab team consisting of 2 prosthodontists and a few youngsters who is really ready to learn and perform along with me. Now, we have learned a new language, the digital language, other than the languages what you speak. It was much tougher than the languages, the foreign languages we know. And now in our hospital, it is all like DICOM, STL, OBJ files. And did you send that file? Did you receive this file? What is the condition of this file? And how we are doing it on a routine basis. So the digital language is set in, and we stopped outsourcing to the maximum, and we started doing maximum in-house procedure. But to start off with the digital dentistry, you needn't be at this stage buying all the equipments, and then to start off with, you can do everything step by step. Like I told, my first case, everything was outsourced. Like even the CBCT was outsourced, even the intraoral scan, that there was no intraoral scan of the soft tissue profile possible. So we scanned the denture, we scanned this on stone model, and we created the soft tissue profile for that patient. And that's why I think we had little bit of this on inaccuracies set in. Though we had 5 to 10% of inaccuracies, we could do a decent job with all the available resources at that point of time. Now, even if you get a CBCT from an CBCT sender, you can ask them for a DICOM file, and you can get that DICOM images in your in your screen, and you can use their software exe what they give, and you can just see, you can scroll in and see, than just reading this on reports. It's always better to have better to visualize the bone profile in front of you in your system. But it takes little time to download the DICOM, to install that software. In your clinical practice, you have to spend some time for that, and you have to keep it ready to discuss it with the patient. And even for your own learning, it takes too much of time. But if you have, again, you can have a VPS impression, that is your rubber-based impression, and you can send it to lab. And they can scan the stone model, and they can create the hard tissue and soft tissue profile merged together, and they're doing the implant planning for you and then giving you a surgical guide. Then, even though they share their planned procedure to you, and even though you have some suggestions to make, end of the day, you are unaware of in what condition they finalized that workflow and what is the best option you had in mind. Is it replicated in the gate system? So a lot of times we had glitches in doing this digital workflow with the outsourced system. That's why we started our learning. It is impossible for a person to learn 10 or 15 different kinds of softwares, but we have to stick on to at least 2 or 3. Because none of these softwares will be so comprehensive to give all the solutions to a dentist or a maxillofacial surgeon or an implantologist. You have to learn few of them. My first learning curve was with R2 Gate. And now, at this point, after around 15 years of digital dentistry, now, I can say we have done a comparative evaluation of these softwares, and we have come out with a paper recently in 2023. We have come out with on a narrative review on all these softwares. And my learning curve in digital dentistry started with doing it your own, like our own digital practices, like digital implant planning and the 3D printed the guide, and doing it in-house. Everything started with my association with Megagen and with Dr. Park. He guided me, and he realized the fact that though we are good clinicians and we are doing a good amount of job in implantology, the future is in digital dentistry, and he guided me to the R2Gate team, and we started working on. The workflow starts like this: creating a digital patient in front of you, a virtual patient. You have to have two scans for doing guided surgeries. For implantology, it is more than enough to have 2 scans, that is CBCT and intraoral scan. But when we do the smile designing and other procedures, you will need even face scan. So restricting to two workflows, that is CBCT and iOS, and we have to do the planning and designing in software, we have to do the 3D printing and then proceed to surgery. The first step is the acquisition of CBCT. Okay, we are getting this on file in CBCT and then the intraoral scan. So now how to merge these two files comfortably to match with each other? That is by STLization. That is the soft tissue profile, you get it as STL file, and the hard tissue profile, that is the scans from CBCT, you get it as a DICOM file. So a part of the DICOM file need to be converted to STL to match with the intraoral STL. That process is called STLization. Once you do it, your CBCT will be in a matching format with STL, and we can do it manually. The matching we used to do. Please, doctors, please mute yourself. Dr. Praveen. Okay. So when we do the matching, we can do 3 points selected from the CBCT as well as another 3 points selected from the STL file of intraoral scan. And we can ask the software to match it for us. And then you can see the changes, what you need to do in the matching, you can do it manually. This was a laborious process and it was taking so much of time in the beginning. Now, these years, last 2-3 years, when we try to do the intraoral scan and CBCT matching, it is very fast because the softwares have adopted the AI algorithm and it's doing it by itself. And around 99% of the matching is done in the first stage itself. And again, we can create a digital teeth, or we can create a digital tooth or a set of teeth in such a way that we can try to do our implant planning as prosthetically driven. So you create a waxer. It is almost like creating a RPD or a vacuum formed tray with teeth incorporated in the stone model and then making a vacuum formed tray and then trying to put the axis through it. So this time we are trying to place the implants. The virtual implant placement is done from the softwares and we try to keep it as parallel, as oriented to the bone, like the implant should be surrounded all around by 1 millimeter of bone. For that, how much deep we have to keep it, or otherwise whether we have to do the bone augmentation or the soft tissue augmentation, everything will be very clear to us. And once we decide the final implant position, then you can freeze that position and you can proceed to the gate fabrication. So there is this an extension of R2 gate system, like that's the software. So to the R2 ware, that is the digital fabrication of the surgical gate, you can decide the extent of the surgical gate, you can draw the boundaries, you can set the insertion point, you can, like how we do the surveying manually, the software will automatically survey the area and we need to give one single path of insertion for this gate. Once the gate path is set in correctly, then there will not be much glitches when you take this surgical gate to the intraoral scenario. And once we do all these things, once the gate is exported as a XTL, then the STL file is given to the 3D printer for printing the physical model. So now the gate fabrication and once the gate is getting ready, then you have to make sure that your drills are going through this gate very passively. So you have to check the integrity of the gate and you have to trim them, you have to polish them, and you have to keep it sterilized using isopropyl alcohol and storing it in chlorhexidine solution. So once you do this alcohol wash and then wash it and then again put it in biosonic for cleaning it properly and then packing and keeping it, then you are ready for the surgery. So understand, dear friends, there is nothing called as universal drilling system. It's always like going with the surgical guided kit from the same company what you have the implant selected. So if you're using Megagen, use the same guided drills and use the same guided principle of Megagen, because it is designed for the thread design, it is designed for the platform, it is designed everything according to the manufacturer's choice. And see, there are two different kinds of diameters of drill holes, what we can get it in Megagen. That is, we have regular and wide implants, because Megagen is a system where we have a lot of wider implants, up to 8 millimeters of wider implants to be used in extraction sockets and other things. But we can do guided surgeries up to 6 millimeters wider implants. So if you are using a guide sleeve of 5 millimeter, then you have to use the regular guide with the 5 millimeter guide hole, and your drills will go smoothly, and the 3.5 to 4.5 millimeter implants can be placed with that regular kit. And there is a definite workflow which you cannot alter. You cannot even alter one drill from the sequence what the software suggests you to do, because there is a workflow demanded from your end to get the correct drilling in the soft bone and in the hard bone, and even from the initial drill of the soft tissue punch, whether you wanted to punch it or you wanted to go through the soft tissue, it is your choice. Sometimes we use a narrow punch to take out the soft tissues and then start with our initial drills. So the initial drill, second drill is always only up to 4 or 5 millimeter to guide the remaining drills into the correct orientation. And the third drill onwards, it will be the gradually increasing in length. Even if you are using 13 millimeters, you have to start from 7, 8, 10, 11, and then 13. You cannot directly jump into 13. So once you do that, then you increase the diameter. Once you get the desired length for your drill, then you try to take the wider drills and you start from 2 millimeters onwards. So when you start drilling from 2 millimeters to 3 millimeter, 3 millimeter to 4 millimeter, you have to keep it in mind the core diameter of your implant, and it is always better to have one size at least. If it is a very hard bone like D2 kind of bone, then it is better to have one size that is undersized osteotomy, one size lesser. Then you try to put the implant in through the gate. If it is getting stuck half the way, release it and go with the next drill. Never ever jump into the final drill and then try for your implant placement. Many times you will be astonished to see that your choice of the final drill was too big and you are losing the primary stability. So always keep one step short and try for it. And if you are not able to do it, then go ahead and do the cortical drilling once more. And then always maintain the vertical depth and the hex orientation in the final placement, so that your implants are as planned and it is seated well in the bone. So once your guide is in position, you are trying to do a flapless surgery and you started drilling in, and you will see that the implants are in 1 millimeter subcrustal, equally spaced from each other, and so this one safe from the adjacent tooth. In this particular case, actually the tooth is tilted and its root is taken too much distally. Even then, we could do a comfortable implant placement. And you can see that in we did this in 2017 or 18, and now in 2025, when you see after 7 years of follow-up, the implants are in the same crustal bone levels, and the soft tissue around it is healthy and neat, and your prosthesis is intact. There is no harm, because we maintained the occlusion, and later we removed even the wisdom tooth, and he had to go for one more root canal in the premolar. See, the kind of results what we could give through the digital protocols, and when we evaluate it after 5 years, 7 years, 10 years time, there is no reason to go back to analog, because the workflow is faster. You get to see all options in advance. You wanted to tilt it, you wanted to keep it straight, you wanted to go more lingually, you wanted to come little more buccally, you wanted to place it little more distally. There is no confusion when you sit in front of a patient. You know where exactly you go, and everything is pre-planned, and your guide will direct you to the right position, safe from the vital structures as well. So all options checked in advance and the best options are selected, and then we go for the surgical kit. See, this particular surgery, when I did, I hardly took this much time only to place the gate in place and to direct my. See the accuracy of the gate and the placement. The drill goes, the final drill goes exactly 1 or 2 millimeters from the 1 millimeter from the sinus flow, and you still have a safety margin. So when you design a surgical gate, or even before that, when you plan your implant position, always keep a safety margin of 1 to 1.5 millimeters from the vital structures. And some of the implants, they have their own inbuilt safety margin of 0.5 millimeter in their implant length. So that means when you say that it is for this on 11 millimeter or 11.5 millimeter implant, it will be slightly short of its distance to compensate any error that we can do in our surgery. So when you do the planning, always keep a safety margin. This is the time we take to do the first implant, and you can notice that the first implant is stabilized with an anchor pin. This is a pin to be attached from the gate to the implant you already placed. If your first implant is primarily stable, you have no worry about whether it is wobbling in the jaw, then you can, of course, you can connect that implant to the gate stabilizing pin and you can proceed with the second implant. As I told you, we are working in a soft bone in the posterior maxilla where we have D3 or D4 type of bone. You cannot expect it to be primarily stable if you do it in a regular drilling base, in a regular drilling fashion. So we did an undersized osteotomy, condensed the bone, and we used a larger diameter implants, and we do a self-condensing implant system in place and high initial stability. And then we wait. Why we wait? It is for soft tissue healing and soft tissue maturation around these healing caps, and this is the result what you get after 3 months time. And this patient is happily chewing with that two implants and with a good soft tissue around it, and doing this kind of surgeries for quite a bit of time. And when I started my research activities, I did a retrospective, multi-center retrospective analysis of our implant cases done in a guided fashion. We did more than 280 cases evaluated. And in multi-center study, that is, I was very happy to get associated with Giuseppe Longo and his daughter Fabrizia, and both the past presidents of Digital Dentistry Society, Henriette Lerner and Marcus, and a younger guy by name Sam Omer. All of us together, we did a multi-center study, and it was published in Journal of Dentistry. And we could say that our implants were 92 to 93% success rate. And even in multi-center, even through multiple hands, in multiple these on working conditions, even then the success rate, success in not in terms of retaining the implant, success in terms of the predictability of the prosthesis and the soft tissue profile around it, the primary stability achieved, and the kind of ISQ values we got, and so many factors we analyzed, and the bone loss around the implants. So keeping all these new parameters of new guidelines for implant success, we could say that our implants were more than 90 to 93% of success rate when we did it with guided systems. Now, my experience, first I started with Nobel Biocare, as I told you, in guided surgery, then to Megagen, and I wetted my hands in multiple systems in guided surgery to evaluate how each and every system works. Now I have around 7 implant systems through my hands, and in that 4 of them guided systems. So I give the choice to the patient. Sometimes people come with a brand name and they ask for, because the other doctor has suggested me to go for this particular implant. Do you have this implant with you? So we always keep multiple brands in our practice, and we try to cater them. And even if I use any other brands, my first criteria is whether can I do a guided scenario with it. So this is my work where we can plan and execute the guided surgery. Yes, bit expensive, but I will say you, it's very predictable, and it's very much stable, and the workflow is very much satisfactory. And in this three-shape software, we were planning for 3.6 and 3.7, and you see this, the concepts are same. You work in any software for implant planning, the primary principles are the same. You have to have a hard tissue profile, and you have to have that much area converted to STL, and then matching that soft tissue profile to that by 3-point matching, and then the AI determines the maximum precision matching for you. And in this software, the in the screen, what you see as green is the matching compatibility, and we are happy to see when all the teeth are in green color, and when you see, when you check in the cross section, you see the nice adaptation of your soft tissue margins to the hard tissue profile what you have. Then you are ready to go to the next step of digital waxer and creating the prosthesis in advance. And you can even 3D print and keep these models, and you can take it through the temporary titanium abutments, and you can place it in that, and you can leave it little infraocclusion, and you can give even immediate prosthesis to the patient. That we do only if the patient is demanding because of the aesthetic purpose. Otherwise, we leave it in infraocclusion with healing abutments, and then we wait for the aesthetic emergence profile to be created, and then to go about with the prosthetic stage. See, in this implant positions of this on pre-plan, and we are going ahead with cross-checking all the parameters of parallelism, the axial placement, and the soft tissue profile, approximation to nerve. Accordingly, satisfying all these criteria, we select the implants in our hand. So when you select these implants in advance, 90% of the time, 95% of the time, I don't have to search for another alternative size. So when you don't need an alternate size, you're very precise. That means you have your surgical guide in hand, you have your implant in hand, you have your patient in front of you, and you have a statement from the software that this is what is planned, this is the type of bone you have, this is the sleeve you have to use, this is the sleeve height you have to incorporate, this is the sleeve position you have to maintain, and you have to use the soft tissue, this on profile cutting with a 4.2, and you are going to use this on drill it in so and so bone, and you follow these guidelines. And once you follow these guidelines, there is nothing less than the finite, the precision what you wanted to attain. You will go to the right position and your implants, and you can load them very early. And this is a case which is done in an immediate loading fashion. And this is another case where we have done a case in a maximum 2 to 3 days time. I think it was done in 3 days time, where we had to replace 2 lateral incisors. Imagine you are able to give the the permanent prosthesis also in 3 to 4 days time, because you have in-house prosthetic manufacturing, and you have in-house this on implant placement, the guided implant placement, and you're sure about the primary stability, and your soft tissue profile is good enough to accommodate a permanent prosthesis in place. Then you have everything in place to go for the fastest protocols ever possible. So these are the implant planning, what we do in-house. And once you decide that, okay, this is the way I need my implants to be in this case, I have used the 16 mm implants of BLX because I really wanted good primary stability, and I don't want to work on the socket. I wanted to go to the basal area as much as possible near to the nasal bone. And we created the gate and used the sleeves. Using sleeves are very much okay in the anterior region, but when you have limited mouth opening, when you are in the posterior most area, going with a this on a 3-piece gated system, like you have your gate, and then you have the sleeve to be incorporated, then you have to use the reducers, then you have to have your drills in place, vertically placed. It's a challenge. But when I do the anteriors, as I told you, the drill sequence and the drilling protocols are there, and you have to just start following the guidelines, do one by one, and just place your implant when the minimal osteotomy is done. And in the anterior region, since we are working very near to the cortical bones in the palatal and this one, we always use equisize osteotomy and then go for the implant placement. Now the implants, once it is in the final position, then nothing stops you from loading it. It was a case with a recession. So we completely placed the implant much above the free gingival margin that is available. Then we created two crowns that were milled in zirconia, glazed with our liquid ceramics called as Mio, and our team of prosthodontists and the doctors, they gave me amazing results in minimum time. My patients walk in and walk out with thanking note because we didn't waste a lot of time. We were to the work. We just started what they really wanted to do, and we are giving them solutions. We can complete even multiple implants in 1 or 2 days. The first day they are coming and taking the OPG, we do a random planning. Once they accept our proposal, then we go for the digital planning. The prosthetically driven implants are this one decided. The length and the width of the implants are once decided. Then we have our gate ready. To do the implant planning, we take hardly half an hour to 1 hour maximum. And then to do the 3D printing, it will take another 2 hours. So in half day time, we are ready with the surgical gate from the time of the patient walking in. And once your gate is ready, then if the patient is okay, we do it in the same day. Extract that small root stems, which are very superficial and very healthy, these are gingival conditions, very clean oral cavity, do the prophylaxis, take the patient, give a shot of local, and then start with your guided surgery. And there is, if you are maintaining all the steps correct from the planning and even in the surgical gate fabrication and even the drilling protocol, nothing less than optimum. This is the result what I can say you. Then we wait. As soon as the patient comes in, we do the planning, we discuss the plan with the patient, we show them, we ask them to sign the financial and this on surgical consent, and then we place the implant and then leave them free for the healing. Then, even though it was a flapless surgery, we place the implants much below and see how the soft tissue develops in 3 months' time. When the patient comes next time, we have to just remove the healing caps, use your scan bodies, do digital scanning, then it goes to our second floor of the clinic for the clinic, this on crown manufacturing. Then, this is the outcome. Even the surgical stage and the prosthetic stage, the time span is cut short to the maximum. So we are buying maximum time for ourselves now. Now, the technology and the digital workflow is working for us, and we are able to manage more number of patients in lesser time. And again, anterior is the replacements, very demanding, very challenging situations where you need to extract, where you need to place your implants parallel, safe from the adjacent teeth, not mesially tilted and going into the incisive canal, but at the same time, you wanted it to be prosthetically driven. You want the access holes to come in the palatal side, and you want enough room for your prosthesis. And if your prosthesis is planned well in advance, and if your planning is in such a way that even before the extraction, you will decide how much deep to go, how palatal to go, how much beyond the socket to go to gain primary stability, but still to be on the palatal aspect and giving emergence in such a way that you will be able to give a screw retained prosthesis for that anterior restoration. So checking it in all three sections like sagittal, coronal and axial sections, and then deciding your implant trajectory, and if you make the gate and if you do a digital workflow, see the result. We are able to give him the temporization in 1 day. The drills are in place. We maintained the vertical limit. We stabilized the gate again with the first implant because the primary stability was that good. Then again we went to the second implant, completed the workflow, checked the stability, it is very high. We gave the temporization then and there, not with RPD, implant retained temporization. That is why it is called a socket seal. It is sealing the entire socket with the prosthesis, and we give graft and PRF into the socket. Then after 3 months, you remove the temporization, you will see good emergence profile, though you can see some granules of the bone graft, but the soft tissue healing is very adequate to go ahead with the prosthetic thing. And when I did this case, I was not having the in-house facility, but it was planned in Exocad, and from the lab side, they gave the prosthesis very much in time, and now we are able to give such a work and a stable work with very much pleasing anterior aesthetic uh, replacements. Is it only for one or two teeth, or is it only for a few teeth in the posteriors or anteriors? No. We can have bone supported gates, or not from the tooth supported gates. We can create the mucosa supported gates and again bone supported gates. In this case, see, after the extraction, we are going for a digital workflow where we are merging the soft tissue scan of this patient. Again, the cast was scanned because it is very extensive area we wanted to capture. Now the latest intraoral scans will give you a very decent enough scans in the posterior most area and in the sulcuses. Like in this case, we have used the scan taken from the regular intraoral scan, again the stone model scan, then the CBCT, matching all these things. Then we could create a virtual patient, and we are deciding now the number of teeth or the number of implants, and again the arch form, where exactly you need your implants, where exactly your multi-units should emerge, and how neat your prosthesis can be. So the workflow is again the same. After stabilizing the gate, you have to start with initial second drill and then again to the 7mm drills, or whatever that system tells you to proceed with. Proceed in each and every implant osteotomy site, and then you can see that all your implants are as planned, parallel to the anterior border of the sinuses, and safe from the this on nasal aperture, safe from the sinus, but in the same platform, all the implants in the same platform. And so one implant is not drooping, one implant is not high, all the implants are in the same platform, so your workflow will be much simple in the prosthetic side. So getting the same results as planned is a challenge when you do the freehand. Then the choice is to go completely digital. Let me frankly say you, my dear friends, I am not a person who go every procedure digital. Sometimes we slow down, sometimes a part of it is done digital, and then we take it to our manual impressions and the manual way of getting our teeth setting and evaluating and making the cast in front of us, and evaluating the occlusion, and then deciding whether to give this kind of teeth setting or not. Now, this is a case done around 6 years back. Even now, the patient is very happily chewing with one arch rehabilitated with dental implants and hybrid denture. Is it not possible to do a full mouth case in a guided way? Of course, we tried multiple cases and we got very satisfying results. See this case where, as I told you, like in a totally edentulous situation, it is a different workflow where we have to manage different scans and merge to the CBCT. And again, the orientation should be that perfect that your guide will be sitting very properly to the patient's this on a ridge at the time of surgery. Now, see this, as usual, we plan the upper and lower arch, the wax pattern and the digital wax up. Then we decide, okay, whether the vertical height or the inter-arch distance is adequate to go for it. That is because the vertical limit is done with the articulation and the scan what you have taken from the wax rims.
It's 12 o'clock.
Again, we can see that once the wax rims and the teeth trials are ready, either manual or digital, then the implant planning starts. So now we decide whether the implants need to be in palatal position or in the occlusal surface, whether it need to be in the lingual surface. And see the anchor pins that is planned, that is for the stabilization purpose. we have to design the placement of these anchor pins in such a way that it doesn't impinge on any vital structures, but at the same time it is engaging to the cortical bone and they are very stable. You will have control over all these parameters only if you directly take control over these parameters. Otherwise, you're depending on somebody's thought process, and if they go wrong, you also go wrong. Somebody is guiding you to a guided failure. The gates are designed from this planning is 3D printed and checked on first in the cast and then in the patient's mouth, then stabilized with the anchor pins, and then the osteotomy and the implants are in. As I told you, then we can connect the multi-units and you can see all the implants are as planned, very much taken to the posterior most position, very much parallel to the anterior slope of the maxillary sinus, and it is with a good primary stability, and it is able to receive a hybrid prosthesis of very good prosthetically acceptable outcome. Then, other than these intraoral procedures, we do even guided surgeries. As I told you, we do guided surgeries in orthognathic, and many times we do zygomatic implants. We started our zygomatic implant placements, multiple zygomatic implant placements in under GA. Nowadays, I do that under local anesthesia because I have strong guidance not to tilt the patient left and right and aim to the zygoma and confused 10 times whether this is the right position, will I get the same emergence in the palatal side, or whether I am going in the correct direction. After putting one zygoma, whether I'll have enough place for the second zygomatic implant to be placed. So my surgical time for zygomatic implants were long hours in OT. Now it is cut short to few hours, not even few hours, like sometimes within 1 hour time. So how we can achieve this, cutting short the surgical time and giving predictable results even in zygomatic implants? That is by having all the preparations done in advance, like 3D printing the skull model and creating the metal guide. We don't have a 3D printing of titanium here in our practice. So we outsource and we take help from outside agencies to create surgical templates in metal, and then we guide our implants to the right position. You can raise the flap, the intraoral flap, very minimal, and you can literally see the zygomatic prominence, and you can see the zygoma proper and the arch. Then with a clean dissection, you can place your surgical guide, you can create the indentations, you can shave off the anterior surface of the maxilla sinus, and again you can direct it to the you can see this, then you will understand how simplified it is now. See, once you do this, and once your implants are in the right position, and you can temporize and you can leave the patient in a day's time, and single zygomas and 2 anterior implants and all on 5 placed in the lower, this is the way we progress. Not only that, we do even quad zygoma nowadays in-house, and this is how we do this. 2 zygomas should be separated well, one to be holding the anterior part of the hybrid denture and the second one to the posterior side, spacing them good, but at the same time getting the good anchorage in zygoma proper. And then once both the implants in place, this is the post-operative CBCT what I have taken to evaluate my placement. Very satisfactory, and I could proceed to the prosthetic workflow without any hassles. So getting the right parallelism in the posterior maxillary area when you do caught zygoma is really challenging. If I can take some very challenging situations like this and if I can perform, I will say it is not just my merits and my orientation, it is with the help of guided surgeries. Of course, your own skills also matters, but at the same time, a person with all these protocols in place, they will do much better. And what about very minute detailing what you need? Like if you wanted to place an implant in the extraction socket, where you're immediately placing an implant in a socket, that is immediate placement, and there are a lot of advantages for it. You can retain the hard and soft tissue around that socket. You're not allowing the socket to heal with the resorption, and then you are not adding the bone oleum, but you are retaining and preserving the bone and the soft tissue around that socket. And you place the implant in such a way that where exactly the cervical line of the tooth was, in the same line, you will place the crust of the implant. And the remaining, your anatomical temporization will give you the emergence profile what you need. So to do this, we need a very, very precise placement of implant in the bifurcation or trifurcation area of the socket. Is it always possible to get a bullseye shot when you do in the posterior maxilla, even if you place the patient tilted upside down and then you peep into the oral cavity and then you try to see all the root sockets, and then many times we fail to achieve primary stability in extraction sockets because our drills going heavy. So now I do both. I do my extraction socket placement with a free hand as well as with a guide. When I use the free hand solutions, I try to use the shorter drills. I have a different kit for short implant placements. I use that drills and I work on millimeter by millimeter to go into the furcation area and the trifurcation area. And then to expand it with the bone expanders, and then to create an osteotomy with the expansion in maxillary arches, and even in the anterior region, as I showed you, like we can create a guided implant placement in extraction socket. Much more challenging is in the posterior maxilla and posterior mandible, where you have less accessibility for the guide and for your drills. Then the guided is the only option. Then in that scenario, we did multiple number of cases, and I did my research work on the accuracy of freehand versus the guided implant placements in immediate placement protocols. And a randomized control trial was done from 2018, the time I started my PhD work, till 2024, that is around 5 years time. Whatever cases we have done it in this fashion, comparing both freehand and guided. Giving good number of cases on each group, we could create a randomized trial and the thesis workup. And I could see that the guided surgery is favoring in almost all the implant placements done in extraction socket. And it is a very predictable option because once you are refined in your guided surgical guide placement and your protocol, that is if you avoid and inter operator variants, like all these cases were done through me, around 80 plus 80 cases and 160 cases done through the same person, done with the same kind of 3D printing, done with the same starting from the data acquisition, CBCT, intraoral scan, gate fabrication, all in one protocol, standardizing all the variables, and then looking for the accuracy levels of both the freehand and guided. Then evaluating and saying that, okay, I could get this axial deviation this much, I could get the depth deviation this much, I could get the buccolingual deviation this much, I could get the mesiolingual deviation from the planned and executed position this much. So how much it varied from your planning and for the execution, the guided surgery was much superior, and especially in mandible. And the conclusions were within the limitations of this study. We say 120 or 140 or 160 is not the number to say that, okay, this is the norm. But still, within the limitations of this study, it is concluded that the guided implant surgery is significantly more accurate than freehand surgeries in immediate placement in post-extraction socket. The surgery protocols does not seem to be influenced by the site of the jaw, but both the surgery protocols showed fewer deviations in mandible than in the in the mandible than in maxilla. So fewer deviations in mandible and more deviation in maxilla. That means the accessibility, even for direct or even for indirect or even for guided surgeries, is difficult in the posterior maxilla. So, concluding with that, we have seen an array of guided surgical cases done from my hands. All these cases were done in my practice through my hands. Let me share my experience. As your experience in guided surgery is getting more and more, your accuracy levels also increases. Maybe your guided fabrication was wrong, or maybe your implant planning was not that accurate, or maybe the data acquisition was not that adequate, or maybe some variables in the fabrication, even selecting the guide resin and the processing and the post-processing of that guide, trimming of the guide hole, and so many factors would have influenced in the initial stages. But I started doing this kind of research activity only from 2019, 2018, 2019 time. By the time I was much refined in my protocols and I was stabilized with all my gadgets and my sound principles were sound enough to compare 2 or 3 kinds of protocols. And now we are setting the guidelines for others to think about various options to be done in guided surgery. Now, coming out with these publications is very important because we show our merits and demerits in such articles, and we set some guidelines for the newcomers to practice. And my respect to all those who wrote initial articles in 2018, 17, and in 19, and even that time there was a publication for checking what are the risk factors in doing guided implant surgeries and how to prevent them. There are a lot of points in it. I will summarize them one by one. Always keep a 2 mm margin in your implant planning to avoid any vital structure. Like if you go beyond the vertical limit through your guide, and if you take one more turn for getting more primary stability, or another one more turn for getting more primary stability, then also your implant should be within the safe margin, that is around 2 millimeters from the planned position. And never ever forget to check the mouth opening of the patient before planning for guided surgery. If a patient is agreeing for a guided surgery and if he is paying a margin for that procedure, the first and foremost thing you have to look into is his mouth opening, whether it is within 35 to 40 millimeters, or is it a 3-finger mouth opening, or you can get it. You can always place one mouth prop in your patient's mouth and see whether if I am able to place a larger dimension mouth prop in the patient's mouth, then I can place my guide as well as I can take my drills to the patient. If the patient is restricted because of any TMJ issues or any trismus or any other conditions, and if you are trying for implant placement through guide, then it is a miserable situation for your patient, and you will stop this procedure half the way because you will not be able to proceed with the guided drills, because most of the guided drills are longer to cross the guide and then to go to the soft tissues and then this one, then to place the implants. So check them out. Then many times you would have experienced, those who are listening to me and having an experience of guided surgeries, whether it is outsourced or whether it is done by themselves, they'll be having an issue of the guide not sitting properly in the patient's mouth. It is wobbling, or it is fracturing, or it is loose, or sometimes it is too tight or something like that, because you are not standardized and you are not sure what resin the lab is using for the manufacturing of the surgical gate, they have to use very stable, biologically inactive materials like biocompatible materials to use in the patient's mouth, and that should have the very least shrinkage during the curing time. So that way we have to be very sure about what kind of resin is used and what processing is done and how much it is light cured, how much it is checked for its stability in the cast. You have to ask, if you're outsourcing, you have to ask the team to give you a surgical gate placed in the cast, 3D printed model, and above that the surgical gate. So you will be able to see whether the gate is sitting properly in the model and whether the extensions are proper. And one more thing I will tell you, when you fabricate the surgical gate, always try to give it cross-arch stability. Even if you are doing 1 or 2 implants in the anterior or posterior region, try to extend it a minimum 3 to 4 teeth anteriorly and posteriorly. If I'm doing a premolar molar in one quadrant, I will be extending it beyond the central incisor of that arch so that the gate is more stable. Most of the time we don't need to use, if since it is a tooth supported gate, we don't need to use the gate stabilizing pins, and we are safe with the stable gate. And if your gate is giving an inaccuracy, if your gate is tilted at least 5 degree from its position it need to be, that 5 degree will angulate your implant to another 30 degree. Keep this in mind. Keep this as a caution. If your gate is not stable, abandon that job and take out your hands, raise a flap and go manually and place your implant. If your gate is stable, blindly go ahead. There is nothing wrong in doing a blind surgery with a gate in place if the gate is accurate. And again, as I told you, check on models. If you're using sleeves, if you're using reducers, make sure that all these things will enter into the patient's mouth even before getting the patient for the surgery. And ensure very passive fit of your drills through the gate. How will you check is, you have your sleeve trimmers and you have your the 3D printed gate trimming tools are there. You can have the same dimension of your implant drills, and you can trim them and make sure that the drills are passively going through the gate so that there is no catch in the surgery. And check all the drills through the gate before starting with surgery. Then without sleeve or metal sleeves, see, when you incorporate metal sleeves, there is no question of passivity loss, but at the same time, the sleeve coming out can be a challenging thing. I always glue them and then I take it to the surgical site. Then, if many times the gate broke, the initial days of our practice, we were surprised why this gate is breaking. We may, it is a 3D printed stuff and you cannot expect too much of strength for it. So once the gate is breaking and if it is losing the stability, then we have to abandon that surgery. We have to again print it. Now this one is like we are using cross-arch stabilization for the surgical gates. Even if you people are outsourcing from any other lab or this one, ask them to give it. And this is having 2 advantages. It will keep the patient's tongue also a little intraorally and it will not come in your way. And second thing is you can keep 1 or 2 gates printed. 3D printing is not that expensive. You can have two gates when you are doing full mouth rehabilitation, and don't depend on one surgical stent. In case if your assistant is dropping, or if in case it is breaking in your hand, or it's not that fragile if you use a very good resin system, and if your 3D printing is good enough, and if your curing time and everything is taken care, then the gate will be very stable. Then again, you have to avoid even micro movements when you do such surgeries. You have to use gate stabilizing pins, and that should be surgically placed. As I told you, when you plan it to the safest areas in your mouth and anchor them well and check for any mobility, then start with your gated surgeries. And the choice of gate with sleeve or without sleeve and reducers, your choice. Some of the manufacturers advise only the sleeved ones. Then you have no choice. If you wanted to use their implants, you have to use that. And whether you wanted to do a pilot drill or you wanted to do a fully guided system, that is again the clinician's choice. Some people try to do it with narrow, these are only 2 mm drills guided, and you get the initial point of entry and the remaining they manage it. Managing is different and doing an excellent job is different. Now let me tell you, I restrict to the pilot drills only in one case, where you wanted to give the implant very near to the adjacent tooth, and that adjacent tooth is going for extraction later, and the adjacent tooth is kept in that place only for taking the support for the gate. And then if you use the final drill, then this acrylic, sorry, the resin, and then the metal sleeve or the sleeveless one, the drills going to the fullest width will be a hindrance, will be hindered by the adjacent tooth. Then I use the pilot drills. That is very rare now. And nowadays we try to do orthodontics and extract the 8, upright the 7, and motivate the patient to go for a short-term orthodontics and then to come for implants. And we try to give the best possible solutions to the patient. And if they say, no, we don't want to go for it, and you please extract and give us 2 implants, and we don't have time to do all these things, then the choice is to go for pilot drills and place your implants, and at the convenience of the patient, extract the posterior tilted teeth and rehabilitate the entire segment. Few key points and some cross check. Have a cross check at every step. From the planning, if you're doing it yourself, or otherwise, even if you're outsourcing, have a strong discussion with the team who is doing it. Ask them all these questions, whatever I suggested in this presentation. Are you doing this? Are you doing that? And are you getting these dimensions? How much it is spaced from the natural tooth? How much from the sinus? How much from the this one? And what dimension you are placing? And whether the selected implant is platform matching or platform shifting or subcrustal placement with conical connection, whatever system you are incorporating, and that system demands the placement, that is to be respected. And always stabilize the gate, I told you, and never mix freehand and gated. Don't use a freehand drill through the gate. You have no control. Unless otherwise it is a pilot drill gate, don't use any other drills through the gate hole. And it should be very implant system specific, and don't mix and match. Don't try Straumann with the Megagen or Megagen with the Straumann, or don't try Simmer with the Nobel Biocare kit, or don't try this one Nobel Biocare with the Simmer kit. So maintain the system discipline. Never skip any implant drills. Thinking that everything is okay, I will use the final drill and I will do it. No. The first few drills are to guide the final drill to the right position. Whenever I did that mistake of skipping 1 or 2 drills, I found that my implant is getting slightly deviated because enough osteotomy was not done in the correct cortical bone in the correct direction. That is why in the final placement, we may not get the right angulation as necessary. Now, can we obsolete all these things and take away all these things and go much guided without any surgical guide, and can we do it much faster than what I described now? Yes, there is a way. That is navigation. I have tried it on a trial basis, not incorporated into my practice yet, but this is the future. Semi-robotic, in-house, if you can have it, that is the best advantages, I will say. It is not system specific. Any implant drills, any guided system, any implants can be incorporated, even zygomatic implants, pterygoid implants in your normal implants, and all-on-4 placements, even resection surgeries, everything can be guided. And this will navigate you to the right dimension in an accuracy of less than 0.001. That means where you planned exactly, there only your drill will go into. If not, the system will be showing signals, or this on audio signals, and this on visual, this on red marks, everything. Still, if you go further, then it is your problem. Otherwise, if you are restricting to what exactly the navigation guides you, I've done 3 cases, and I'll say it is amazing result. And let me tell you, this is the future. Start the first steps in digital dentistry. Whether you own it, whether you outsource it, doesn't matter. Try to do the guided and digital implant placements in your practice. Understand where you go wrong. Discuss with the senior people who really wanted to guide you and who are ready to support you. And I am sure Digital Dentistry Forum and Dr. Busin Khan, they are all into training the newbies and very novice people to and get them into the mainstream of digital dentistry and implantology. And with this, let me thank the entire team and let me thank all those who uh, patiently listened and were with us. Let me thank each one of them. And let me say the last thing what I am showing is the accuracy levels what we get with in an angular deviation with navigation surgeries. So let us develop the better digital half of ours. Thank you so much. Thanks for the listening.
Thank you, Dr. Segin Chandra, for this excellent presentation where I think you covered almost all aspects of digitally guided implant procedures, taking them from delayed to immediate to even zygomatic procedures made easy. Just striking up some discussion for the next 10 minutes before we wind up. I would like to pose this question. Of course, participants, you can also pose your questions on the chat box here so that we get an indication. Sejin, can you stop the screen share so we can have a full screen here?
Yeah.
Yeah, thank you. So my chat box says that can we have the recorded video? Yes, we will be sharing this video on the Facebook group of Digital Dental Forum as well as on our website, which is www.digitaldentalforum.com very shortly, and you could access these videos whenever you want to get in there. Okay, like I said, let's strike in some nice conversation here. We spoke about, Sejin, you spoke about outsourcing CBCTs and outsourcing surgical plans. Could you just tell our participants here as to the reliability of these and what is the caution that one has to take when or certain instructions given or being a part of this whole system of planning?
You cannot, I hope I am audible.
Yes, absolutely.
Many times it is beyond our control, like the neutral position of the head and the CBCT or the OPG taking or the positioning of the patient for the scans. That is one challenge. Second thing is when you send the patient for CBCT, many times the softwares, they will have their own software for viewing, and that will be given to this one clinician, but many times it will not be compatible with the system what we have, or we lose that patience and we go with only with the reporting. I discussed it with many friends of mine, and then I realized that 70% of them are not using the CD what the center is giving to them, and they rely on the only the printed report what they get. So in that, one more thing is in the printed thing, what you get is the long axis. Sometimes when how the cross section is taken, whether it is with the correct 90-degree perpendicular axis or it is slightly tilted. If it is tilted, then the long axis will show much more bone than how it is in the patient's mouth. So if you rely on a CBCT taken from outside, and if you are not exactly in the perpendicular to the occlusal plane and or parallel to the adjacent teeth, and you will get an exact axis line, but may not be the same in the patient's mouth. So that is why with a lot of financial burden, we all went ahead and purchased a CBCT machine, and then we went ahead with our own planning and execution. And it is, CBCT is not just for implant planning alone. It is for endodontics, it is for your routine investigations, everything. Like it opens a Pandora box for you when a CBCT is opened in front of you. So second thing is like, you have to give some guidelines in this position and in this way we need, especially when you send the patient for CBCT for implants. It is better to send them with a denture or a this on what to say, the separating gauze piece or a cotton roll so that they bite on it and the teeth are well separated to have the scans. And the second thing is, if you are taking the fiducials and if you are taking some reference points, the denture of the thing what they are wearing should be exactly in the position where it needs to be. That's the real challenge. Otherwise, you have to go with the patient to the CBCT center and you have to take a lot of time in getting a CBCT done for implant workflow. Then what else we can do? And in this heavy traffic of your city and going from one place to the another, you will hardly treat one patient or two patients in that way. Then coming for intraoral scanning, nowadays so many different labs are coming and scanning the impressions, and that can be a good resource. If you are not able to afford for a intraoral scanning, then you can always scan your, you can send a cast, but sending a cast again, it's a challenge. You have to keep the cast in such a safe way that first of all, you have to get the plaster model out without any breakage and without any deformities and without any distortion. And again, even if you get that, till the scanner is available, that's a challenge. Otherwise, the scanner should come to your place. Many labs are offering the scanning service to your place. Okay, they can come and do the scanning, then that's okay. In the initial stage, it is fine. But when your cases are more and you wanted to do 3 or 4 scanning in a day, if you are doing more than 10 patients a day, I don't think it is feasible to hire the intraoral scanning very now and then. Then again, what else we can outsource? The planning. Of course, if you don't have a this one planning software, now with a CBCT machine, there will be a planning software for the implants as well. So, yeah, accurate planning can be done with any of the CBCT based softwares. Let it be Sirona's Sidexis or Galileo's or K-Streams or any PlanMecca softwares. There will be an option to see the cross sections and to put a virtual implant there and to see how much it is viable to place such a long and such a wider implant in the place. But that is only the planning. And if you wanted to use that for, see, it is only for diagnosis. When you wanted to use these gadgets for diagnosis, treatment planning and execution, then only the complete investment is viable, I will say. You have to use it for diagnosis, treatment planning, and for creating the physical models for execution. All these three, when it is together, it is win-win situation and you will be doing n number of cases in your practice. Don't hesitate to invest, and you have to slowly get into this mainstream of digital and creating the digital models and see how the workflow is happening from the third-party solution. And if you are satisfactory with that team, proceed, see the accuracy levels what you achieve. Then if you wanted to have a change, you can think about changing that to in-house.
Yeah, I think that's very well noted. I think so important part is that generally when you get a report from a CBCT center, it is in the format of a PDF, and that's not what you want, because if you want to be a part of the planning, like you said, it depends on how the panoramic curve is marked, how the section is taken. It all depends on what the technician was doing at that time without knowing what you want. So you need the DICOM file of this so that you can be a part of this whole planning process. And of course, like you mentioned, again, in terms of the implant planning, you need an additional software. So there's an additional investment, which also can be outsourced. But when you're outsourcing, you have to be a part of that whole planning process with the center. I think that's very important. So there is a question from Dr. Kaustub. I don't know why he's asking this, but he's asking whether we can change the DICOM to an STL file.
Of course, there is an option in the softwares where you can change, you can select the area of the DICOM and you can change to STL. That software will do that for you. You needn't do anything else. You have to select that area and click a buttons to say that DICOM conversion to STL. And then that area only will be able to match with the intraoral area. So we have to see how much dimension of the jaw you need it in STL format. You need to have from the incisal edge to the posterior most area you need, then you have to select that much. But in a regular CT, there will be a lot of areas from vertex to the mentron, and you don't need all those areas to be converted to STL. You need to convert only that limited amount of the jaw area to be converted to STL for matching with the right intraoral scan what you have. But when
So
you do face scan, when you do matching with the face scan, you need the entire area to be matched with the face scan.
okay. So just to add on there, I think the only time when you would need that is when you have a template or a denture or for full arch situations when you're taking the prosthesis DICOM and then converting it to an STL for matching purposes is one of the reasons why you would need to convert them to STL. Otherwise, of course, iOS softwares would do the needful. So there is also a question from someone here who is asking as to which is the best iOS scanner. Tricky
Anything
one.
in the latest version, because these companies keep on changing their technology, and the R&D that is happening in this field is so fast. I will say this is my second generation scanner. I bought the first scanner was Omnicam from Sirona, and it was not that fast as expected. And they told they will do some software conversion, this, that, and that's the time the Prime Scan was introduced. So I gave back the Prime this on Omnicam, and I took the Prime Scan. So very happy with the latest technology one. Maybe in Trios also, Trios 3 and 4, that will be much advanced than the previous version. And in every company, there will be a latest version of their intraoral scanner. If you are with it, then you will not regret it. Otherwise, to changing that this one in 2025, if you take a 2000 model, this on intraoral scan, I don't think it is a acceptable scenario. Like you will be behind the ages. So go for the latest version possible and use it to the maximum. And when there is a technology upgradation comes, you have to match with it. There is
Yeah.
no other.
I think if you were to go and buy an iPhone today, you would buy a 15 or a 16 and not buy a 9 or a 10. That's
Yes.
the same reason. So I think more or less iOS systems are good now in the market. What you have to look for is the trueness of the image that they produce, the stitching that it has. So it's also more software related. So what software is providing you in each of the iOS systems is what you have to see, and of course, another important part is what is it that you want to spend. So there are scanners in the high-end bracket, there are scanners in the mid bracket, and then there are equally good scanners in the low bracket as well. But it depends on what usage you have and what are you going to use it for. So, and the budget, of course.
One
So,
more thing, I will say it in three words: speed, accuracy, the depth of scan. These
yes,
three parameters. These are the three parameters to look for. If you're satisfied with these three, go ahead. Any brand, it is fine.
budget, both.
Yes, fourth.
Okay. You also mentioned, Sajjan, about AI in planning softwares.
Yeah.
Do you think that that has really helped people improve the accuracy or the speed of their planning processes?
Yes, very much. The time I started using R2Gate was around 7 or 8 years back. Now, what I see is an amazing change because the matching was very, very much done with the manual and then going for the precision matching. The time taken for the STL to match with the DICOM and then to move on to the implant planning, that phase was very long. Now it is very fast within few minutes, not even minutes, within 1 minute time, the first initial, the DICOM loading and the matching will be done. And even in 3Shape, the new softwares with the latest upgrades, like it is all like faster. And even prompting, like you need to do this or you need to do that. Like there are a lot of this on new added features to every software. Like, and one more thing is the implant libraries. One person cannot stick on to one single implant system. So the library is very vast now. So most of the softwares, see, like even Israeli implant systems are with their STL files incorporated with planning softwares. So gated is not for only higher brands now; it is for everyone. Gated surgery is becoming so popular because it is available for each and every system now.
That brings me to the next question. Is guided surgery for an starter in implantology, or does it require some hands-on experience with analog systems before you get into guided?
I will say you should be wetting your hands with almost all the aspects of implantology and a good training from your mentors, and then only you should start thinking about guided surgery. It's not a shortcut from your skills. Take it from me. If you're blind about your procedure and if you're just drilling in, then mishaps can happen even in analog and even in digital. So you have to be a trained person to get into digital side and to do one by one, do single implants and then multiple implants, then bridges, then full arch, then full mouth, then maybe deficient bone management, and then again you can go for tilted implants, pterygoids, zygoma. You can do anything. That is, the sky is the limit. Then now we are doing PSIs. I didn't touch that here. We are when there is very very less bone and we have no bone to place an implant, then we will have our old type of subperiosteal implants that is designed and then lateral screws done, which will have the abutment incorporating facility. The hex will be incorporated in that. So to that extent, we are able to do. So it is a solution for many challenging situations. That's all I will say. It's not a shortcut from regular dentistry at all.
Absolutely. Okay, there's a question from Dr. Shreya Shetty, and she's asking whether there are one factor in for hard tissue grafting with guide fabrication.
Yeah, see, the biggest advantage of guided surgery is you will be trying to place your implant in the most ideal position, and then you will see how much bone is around that position. If the buccal side bone is deficient, you will get to know that very easily. Sometimes we try to keep 1 mm short implant and then to go little more subcrustally so that your implant is much more into the deep into the bone, and we will shave off the superficial this on layer. Like imagine you have 11.5 millimeter crustal height. In that 2 millimeters are with a sloping surface, and you have more this on sound bone towards another 2 millimeters down from the crust. So we will plan our implant 2 millimeters subcrustal, and we may shave off the superficial bone by raising a flap. And then we place, otherwise we use a bone trifine that is called as profile creators. We can attach a small stump in the implant and we can create a bone profiling. So once you do the bone profiling, you can keep the larger diameter abutments and you can create a profile. So if needed, there are so many shortcuts to avoid bone grafting in implantology, but once it necessitates that, then you have to be, see, we have done even ridge split and then going ahead with guided placement. In that, then once you're a master of this one, then you will have your own pinch of salt into it. That is, when you wanted to do the precise placement from the mesiodistal dimension, you will create a template ready for the implant placement, but you will open up, you will do the ridge split, create the split ready, then you put this on guide, and through that guide you will place the implant. And at the same time, if you wanted to do a guided bone regeneration, of course, you do that implant place, raise a flap and keep it, do the implant placement with the guide, then do all the augmentation procedure and close it. It is, as I told you, it is same like analog dentistry. It is like a, this one. It is not a magic wand. It is an assisting tool in your hand.
Absolutely. So it will enhance your practice.
Yeah.
One question from Dr. Janine, and she's asking as to any advantage of an early placement versus an immediate placement guided.
Early placement, see, these are different protocols. Early placement, this is an immediate placement and delayed placement. Early placement, in my choice, around 2 to 3 weeks time, then it should be an open surgery, and we should curate it out. If there is a soft bone in that, we should curate it out, and the fibrous content should be removed completely, the granulation tissues and other things, and then go ahead with just make that area similar like an extraction socket and then proceed. That is my this one, because if the extraction is not done by me, because if I do that extraction, I would have curated the granulation tissues and the socket will be debrided thoroughly, and even if not placing a bone graft, at least a good this one socket sealing with Abgel or something would have done, so that once you raise the soft tissues, the bone will be visible in its healthy situation. One more thing, the time I do the early placement is only in one condition, when the tissues are sloughed around the tooth and it needs to heal up, then I will not take up that case for immediate placement, because even after the immediate placement, the coverage will be very tough. So take out the tooth, wait for the soft tissues to heal, open up after 2 weeks or 3 weeks time, then do it as an extraction socket, but with a healthy coverage. That's it. Other than that, I don't see any other added advantage of waiting for 2 weeks time.
So then, can you throw some light on flap versus flapless guided?
I have done both. I have done both. But I'll tell you, when you're sure about, when you're 100% sure about the placement of implant in the native bone, and your bone quality is good enough, then go flapless. And if your tissue thickness is more than 3 to 4 millimeters, and it is good keratinized tissue, then only you should go for flapless. Otherwise, you will be punching the excite keratinized tissue from there, and your implant margin will be in soft mucosa, and the longevity of that implant for crustal bone loss will be a questionable thing. So it is always better to wait with a flap and then doing a guided surgery and then close it. My choice is like I do a small nick incision, raise a full periosteal flap, even if it is for a molar. I do the guided surgery. I see from the buccal side, I visualize the implant placement, then I put the healing cover. If needed, I'll put little graft there, and lot of this on keratinized tissue, because I always give a slightly off crustal incision so that maximum keratinized tissue is brought to the buccal side to counter. See, even if there is no bone graft, if there is good tissue thickness and your implant placement is subcrustal, there is nothing to worry about the contour. That soft tissue will heal up, and you have seen beautiful profile creation what I have shown with guided surgeries. It's not because it is guided, it is maintained with the soft tissue management. Like we make sure that at the end of the healing there is enough soft tissue around the implant. If not, we have to depend on our perio skills, taking a connective tissue or a free gingival graft and putting it on the buccal side and close it. Even if you don't want to put a graft, it is fine. If you are capable of taking a connective tissue graft and put it in the labial side or buccal side and close it along with the correct ideally positioned implant and suture it around the healing cap, then you are done.
So
So
I think,
healing will show amazing results.
yeah, so the conclusion was that the biotype and the attached keratinized gingiva play an important role in deciding whether you
Yes,
go
very much.
or
Very much.
flapless. Yeah.
Yes.
Okay. Quickly, one more question coming on is sleeve versus sleeveless guides, and what do you think is the best uh, guide material that's coming from Tanveer? Best surgical guided material for implants. Yes.
Material of choice is surgical grade resin. You have to use that. There is no shortcuts. The first time when I outsourced and somebody gave me a green color surgical guide, I was really surprised, and the vendor told me, yeah, we make surgical guide in different materials, you try this. The later I realized that it is not at all a surgical guide resin, it is something different, and we cannot rely on that. So the clear surgical guide resins manufactured by the companies that should be used for the fabrication of surgical guide. One more thing is the resin leaching into the soft tissues. If it is not cured properly, there will be a slight leaching of this methacrylates into the soft tissues, and that will create problems later. So better, the biologically acceptable and biocompatible material is only the surgical resin, and you insist on getting it done in that. And of course, the gates fabricated in that will cost a bit more than the regular gates, and it will be done in standard dental labs. And you have to accept that price and you have to go for it. Second question was about the material, and the second
Versus sleeveless.
of course, first guided experience was with the sleeve, but with all great struggle, we stabilized the stent and through the sleeves and reducers, holding the reducer in place and then getting your handpiece in position, maintaining the vertical this one position in the long axis drilling, in the pumping motion. All these things are challenge. I take the guided surgical system with the sleeves only to the anterior and maximum to premolar region. I don't take it much longer than that. Maybe when I get more experienced in that, I may have more confidence. But when I have a sleeveless system which can incorporate shorter drills and give me that results, I go for it. It's like where you are confident of. And there is nothing wrong in using a sleeveless system because it is designed in such a fashion to incorporate that dimension of the drill, and the drill hole is designed in such a fashion to limit the vertical depth and to maintain the mesiodistal and bucolical directions. Unless otherwise the gate breaks, it is completely safe. And the areas of inaccuracies are less. If the gate is having an inaccuracy, the sleeve is having another inaccuracy, and if any one of the components is moving, then it is a challenge. So I always prefer to have a sleeveless system, to tell you very frankly.
Well, on the other side, I think the deviations that you see in a sleeve system is much less because it's a metal to metal contact versus a resin to metal. And of course, to add on to what you said, besides the reducer or the index, you also get a sleeve to shaft where the osteotomy drill itself has a shaft which engages the sleeve. So you eliminate the reducer completely, and therefore it becomes easier to use.
To tell you very frankly, I have not used a system with the sleeves incorporated to the gate, but to the drill. I always had these reducers in my hands. Maybe I will try some more systems that is more flexible now.
Well, in getting to the full arch guided, we spoke about different scans that we need for a full arch. Could
Yeah.
you elaborate a little on that as to what do you exactly need for a full arch situation to get that superimposition of the STL and DICOMs?
Yeah, one is the entire arch should be DICOM, should be converted to STL, and that is first STL. Second one is we are taking a scan of the intraoral scan, or otherwise a stone model scan of the edentulous area. Second, and the third will be a bite scan that is recorded with the bite the rims. And the previous generation scanners will not take this wax pattern this on recorded properly because of the shiny surface. We have to spray some this on gray paint over it, and there are some sprays that is available from this Densplay and other companies. We have to spray that and take a scan of this vertical limit, that is the jaws, this on bite rim scans. All these scans should be merged well so that this the whole vertical limit and the this on what you call the plane of occlusion and this it's actually like a virtual Facebook transfer. Though see nowadays the most of the people can most of the softwares can incorporate Facebook scan accepted, and a digital incorporation of various limits, and then we can do the virtual transfer of that scenario. But whenever I did, I was not very confident of going through that scenario. That's why we took the regular bite blocks and jaw relation, sealing them, and then scanning that, taking that vertical dimension as our reference point. Then the jaws are aligned. Then we go for the, I have not incorporated that slides. Usually we do the articulation outside with one gate and our opposite bite rim. Then with that only we align the this one gate to the jaw with that alignment, because if you wanted to place the upper gate to the position, you should have a guidance from the lower arch. That means a bite relation should be ready, and your articulation should have that indentations of the upper gate in the lower wax rim, so that with that the patient can bite, and then with that you have to put the lateral screws in so that the this one gate what you fabricated is going into the right position without a tilt, or it is in the right direction, and then sealing it in that position and then starting with your surgery. Same thing opposite. Once you wanted to do the lower, then you have to stabilize the lower arch with the bite rim from upper, and the gate should be stabilized to the mandible in such a way that there is no deviation in the midline or the arch form is not altered. Then maintaining that scenario, we have to put the lateral fixation screws.
Great.
Otherwise, it can have a bit of inaccuracies here and there in the first one or two attempts of yours. Slowly you will come to know like where you went wrong, and you will get adapted to the challenges you faced.
Okay, so now I think before we close our session, last question. What is the most common troubleshoot that one most common troubleshooting in a guided static guide process that you would come across, and how do you encounter this?
The most common troublesome procedure and how we counter it.
Yes.
That is the first thing is what we can say. Most of these things have occurred in my practice, and we have come to a refined situation now. The most common scenario can be like the mobility of the gate. If the wobbling of your gate, that to counter it, as I told you, that should be this one taken care from the beginning. Cross arch stabilization, and if it is the saddle type of posterior most area, then you can try to incorporate a pin to attach it. So you have to tell this one gate manufacturer that I am working in a posterior extension area where there is no teeth to support it. So it all depends upon you are using tooth gated or partially mucosa gated. Then you have to stabilize the gate. Otherwise, you will not get the right results. Yeah, that can be fixed with, see, it should be taken care in advance. I told you, like that once you get a trouble in guided surgery, it is a real trouble. You have to stop that procedure and you have to move on to in an analog fashion. Because if you're doing it with a wobbling gate and if you're trying to drill in, you will go to 30-degree, 40-degree deviations from the planned position. You will see your implant ending up in adjacent to the root or otherwise to the sinus, otherwise to the distal most area, making more complicated than the analog scenario. So if you take care of these small aspects in advance and then you plan your gate, then the things are in your control, there is no hassles. You will do more number of gated then. Once you
Absolutely.
gain confidence, you will be doing it left and right. You will not do regular surgeries. You will wait for a day or a half day and you will ask your team to prepare the gate and then proceed. First
Yes.
thing coming into your mind will be guided surgery, then only the analog.
So fit of the guide and guide fractures, I think, is
Yes,
commonly encountered, and I think that's more to do with either the design or the material
yes,
used or various other aspects which can lead to such problems. Therefore, if somebody is getting into guided surgery, please use the right protocols and make sure that you follow them, as Dr. Segin has also enumerated them. Because if you do not follow them, if you're just depending on a center to give you what you want, and you get into the procedure, you fail, and then you just give up on guided surgery. So every procedure has troubleshoot, every procedure needs protocol, and please follow them. Uh, to end this note, let me thank Dr. Segin for this wonderful session. And mind you, participants, we will have the second part of the session on 20th of April, which will take you through the prosthetic part of guided processes, again by Dr. Segin. And do follow us on our Instagram page of Digital Dental Forum. And we also have a Facebook group of Digital Dental Forum. Follow us there where we will be posting these videos. We have our website where it will be also kept on the content section of our website. So be a part of the forum, and we hold regular workshops and training sessions as well as conferences on the same. Thank you very much for being a very patient audience on a Sunday morning. And thank you once again, Dr. Sejan.
thank you. Thank you, Bosin and team DDF. Thank you.